Hey everyone, it's Mikki here. You're listening to Mini Mikkipedia on a Monday, and today I want to chat about lipoedema. It's a condition that has been underdiagnosed for many years now, and we used to think that it was pretty rare, but the more that I'm talking to women, the more that I'm seeing online, listening to podcasts and conferences I've been to over the last couple of years, the more I understand that actually the prevalence is far greater than people thought. So lipoedema is a chronic adipose tissue disorder, and it primarily affects women. The prevalence is around 10%, but in some studies you'll see 11 to 40% depending on the criteria used. And obviously that's a huge range, and it does tell you something about how inconsistently it's studied. The hallmark of lipoedema is a disproportionate, symmetrical accumulation of fat in the lower limbs, thighs, hips, buttocks, sometimes the lower legs. The hands and feet typically spared. That foot sparing is actually one of the diagnostic criterias. And women describe the tissue as painful, tender to touch, easy to bruise, and completely unresponsive to diet and exercise in the way general body fat responds. And this is the crux of the whole conversation. It isn't a perception issue. The tissue itself is structurally different. It's characterized by adipocyte hypertrophy, which is the growth of the fat cell, chronic low-grade inflammation, fibrosis of that extracellular matrix, lymphatic dysfunction, and mitochondrial changes. So it isn't excess fat in the usual sense. This is a pathological tissue with its own biology. And this is why sort of maybe standard advice around diet and exercise doesn't work the way that it would otherwise would. Women with lipoedema can absolutely lose general body fat through caloric restriction and exercise, but the affected tissue, the disproportionate lower body accumulation, doesn't respond the same way. So you can get a woman who has really committed to everything and still looks exactly the same below the waist. And then she feels like she needs to be trying harder, even though she literally has done everything. And that obviously is frustrating for her. And if you're told you need to be doing more, that could be damaging just from a psychological perspective, right? So I will be clear though, diet and exercise definitely are valuable tools in lipoedema management, but they're just not doing the same job if that condition wasn't present. So what type of dietary approach are people with lipoedema best suited to? Now, I came across information on the ketogenic diet, which I'll talk about in a little bit, at the San Diego conference that I went to, the Low Carb USA conference, which was super interesting. However, in 2025, there was a systematic review on dietary interventions in lipoedema. There were only 9 studies, so, it's pretty sparse on the ground, and only 269 women in total. And the conclusion was essentially that the effects of dietary approaches remain unclear, and we needed larger, more rigorous trials. However, the data that we do have points fairly consistently in one direction, and that's towards lower carb approaches being useful. I mentioned the ketogenic diet before, and this isn't for removing the lipidemia tissue, but for managing inflammation, reducing pain, and preventing the condition from progressing. The best human trial we have is a randomized controlled trial published in 2024 by Lundanes and colleagues in Norway. They took women with both lipedema and obesity and randomized them to one of 2 diets, both set at 1,200 calories a day over 8 weeks. One group followed the low-carb diet, 25% of energy from carbohydrate, 55% from fat, so it's not quite ketogenic. Others followed a standard low-fat controlled diet, 60% of their energy coming from carbohydrate, 20% from fat. You can see then that the low-carb diet is slightly high in protein. The finding was that low-carb diet was superior to the control diet for reducing pain. Both groups saw some quality of life improvement, but only the low-carb group showed significant improvements in symptoms, feelings about their condition, and overall quality of life scores, which is super interesting. The researchers also looked at body water changes, including intracellular and extracellular fluid, and found no significant difference between the groups. Both groups lost similar amounts of water, and there was no association between water loss and pain reduction in the low-carb group. The reason I mention this is because an easy dismissal of low-carb diets is that any benefit is just fluid loss. glycogen depletion, pulling water out. That doesn't appear to be what's driving the pain improvement here. So, clearly something else is going on. There was also a Polish study from 23 which found that a low-carbohydrate, high-fat diet improved body composition, reduced leg volume, and decreased pain in women with lipedema compared to a control group with overweight or obesity. And that was from Jeziorek and colleagues. So the picture is emerging that carbohydrate restriction appears to reduce inflammation in that lipedema tissue, and that translates to less pain and better quality of life. And the mechanism that's most widely proposed is that a high carb intake in someone who already has impaired lymphatic function and chronic low-grade inflammation may amplify that inflammatory load through insulin, through inflammatory cytokines, through prostaglandin pathways. Reducing carbohydrate appears to reduce that signal. Now, that same Norwegian group also have a 2025 paper that looked at plasma fatty acid composition following these two diets, following either the standard diet or that lower carbohydrate, higher fat diet, and found that changes in fatty acid profiles were associated with pain reduction. So that anti-inflammatory mechanism may partly be mediated through the types of fat circulating when carbohydrate intake is low. So it's mechanistically plausible because, of course, we are what we eat, if you like, in terms of the types of fats we have stored in our tissue. And it is consistent with what we know about how diet fat quality affects inflammation. Now, in terms of broader dietary guidance, the 2024 German S2 clinical guidelines on lipedema, which is currently the most comprehensive evidence-based clinical framework there is, includes a strong consensus recommendation for the Mediterranean diet and consensus support for the ketogenic diet. So the pattern is anti-inflammatory diet approaches, whether you frame that as Mediterranean or low carb specifically. So just to be clear, these diets do not remove the lipedema tissue. It's just managing that inflammatory environment that drives pain and disease progression. And it is preventing secondary obesity, which does matter a lot, obviously, because women with lipedema often develop generalized excess fat over time as a result of pain-related inactivity and mobility limitations. And that secondary weight gain is not lipedema tissue. That responds to caloric restriction, and carrying it worsens lipedema severity by increasing lymphatic load and mechanical stress on already compromised tissue. So diet management that prevents or addresses that secondary layer is obviously worthwhile. And of course, protein is also worth mentioning. When isn't it? There's no specific lipedema and protein research that I can point to, but from a general body composition perspective, adequate protein, 1.6 to 2.2 grams per kilogram of body weight matters for preserving muscle mass, supporting lymphatic function, maintaining metabolic rate in the context of what is often a chronic pain-limited condition. So what about exercise then? Exercise in lipedema is also like a conservative management tool. So it's not about burning the fat off. It's about managing lymphatic flow, maintaining mobility, reducing pain, supporting mental health, and slowing disease progression. So the lymphatic system doesn't have its own pump the way that the cardiovascular system does. It relies on muscle contractions, breathing, and movement to move fluid through the body. So in a condition characterized by lymphatic dysfunction, movement is therapeutic in that direct physiological sense. A 2022 proof of principle trial that used physical therapy combining manual lymphatic drainage, MLD, compression, and exercise in early stage lipedema found that there were reductions in pain and improved function after just 9 therapy visits. And when they used a way to measure sodium MRI to sort of objectively measure that tissue sodium, which is a marker of lymphatic stress, they found reductions in the treated limbs. So having that objective measure is, really interesting. The types of exercise most commonly recommended are low-impact activities that create muscle contraction without generating excessive mechanical load or inflammation in the affected tissue. Swimming and water aerobics sit at the top of the list because water provides that natural compression while allowing a full range of movement. Cycling can also be well tolerated. Walking, obviously. Rebounding, like using a mini trampoline, is often mentioned for its lymphatic stimulation effect. Depending on the disease progression, high-impact loading activities like running, jumping, or heavy lower body resistance work don't tend to be as well tolerated because they can increase that pain and swelling. So it's really important to be mindful of that. Currently, there is a randomized trial underway in Norway, looking at 8 weeks of supervised HIIT training in women with lipedema, with body composition, pain, and metabolic outcomes as endpoints. So that'll be super interesting to see this emerging evidence in the coming years. The broader point on exercise is that remaining mobile is really protective. So women with lipedema who maintain physical activity tend to have better outcomes, slower progression, and more stable body composition. Inactivity worsens that lymphatic stagnation and contributes to secondary obesity. So while exercise isn't going to change that underlying tissue, it absolutely matters for the whole picture, and particularly in those early stages to help prevent that sort of secondary layer of obesity that often women experience once that pain gets to that debilitating part where they can't actually exercise properly and burn calories. So surgery is actually the most effective intervention for the tissue itself, based on the information that I have at hand. Liposuction, performed, it seems, in a particular way for lipedema compared to just general liposuction to protect those lymphatic vessels. That's currently the most effective intervention we have for directly addressing lipedema tissue. And the current literature describes it as the only intervention that can actually remove that abnormal tissue. So the adipocytes, the nodules, and that fibrotic extracellular matrix, and the only intervention with the potential to halt disease progression. The outcomes data is consistent. A longitudinal study of 25 patients across 72 procedures found significant reductions in spontaneous pain, pressure sensitivity, tension, bruising, cosmetic impairment, and quality of life impairment. And they were sustained at 16 and 37 months post-surgery. So that's 3 years after surgery. And a meta-analysis confirmed these findings across multiple studies. The meta-analysis also suggests benefits can persist for up to 12 years. And a more recent series of 47 patients showed significant reductions in depression and anxiety following surgery. So with people who had a more progression of the disease, having a most substantial quality of life improvements, which is super cool. However, let's just say that the surgery itself, it's not a cure. So in most studies, more than half the patients still required some level of that conservative management, like the compression garments, the MLD, after surgery. And it doesn't work the same way for everyone. Obviously, the stage of the disease, your body mass index, or the excess body fat you're carrying, and comorbidities all will affect outcomes. But for women who meet the criteria for surgery, it does change their quality of life. Now, just to note, bariatric surgery is not equivalent. Studies have looked at what happens when a woman with lipedema undergoes weight loss surgery and loses substantial amounts of weight. And the finding is that significant generalized weight loss does not reliably improve these lipedema symptoms. The tissue is the problem, not the weight per se. So targeted removal of that tissue is what matters. Surgery isn't first line. Just to be clear, it's very effective, but the standard clinical pathway is a confirmed diagnosis, then that conservative management, and if that management is insufficient, surgery is considered. And in places like New Zealand and Australia, it's often classified as cosmetic rather than medically necessary. And that clearly does sort of create some access barriers. And what about GLP medications? Semaglutide, tirzepatide, where do they fit in the lipedema management? It's evolving, and I would say the evidence is early, but the rationale is compelling. And the angle that's interesting specifically with lipedema isn't the weight loss per se, it's anti-inflammatory and metabolic properties. Lipedema tissue is characterized by chronic low-grade inflammation, and GLP-1 receptor agonists have real anti-inflammatory effects that are increasingly well documented across a range of conditions. There was a 2025 case series followed 5 women with lipedema and insulin resistance who were treated with GLP-1 medication, exenatide. So researchers observed reductions in pain and decreases in subcutaneous fat thickness. So what was particularly notable was some of these women improved even without significant weight loss, which points to that mechanism beyond just fat reduction. There is something about that anti-inflammatory pathway that appears to work. So you may be wondering what exenatide is. You wouldn't have heard a lot about it probably. It is a GLP-1 receptor agonist, much the way that semaglutide is, but it's the earliest in the class. So it was approved for use for type 2 diabetes in 2005. So it sort of sits along the same class, but it's not as effective as semaglutide, which you find with these newer generation of these types of drugs. So just wanted to clarify that. There is a study on tirzepatide specifically, or at least a narrative review, and it was published in 2025, and it proposed that this dual receptor mechanism, which has both GLP and GIP agonist, it gives superior effects on the metabolic and inflammatory biology of the adipose tissue compared to that single receptor agonist. And the researchers in that 2025 narrative review argued that tirzepatide may have, disease-modifying potential in lipedema. So it may affect that underlying fibrosis and inflammation and not just body weight. There was a case report from the 2025 Endocrine Society meeting, which described a 34-year-old woman with stage 3 lipedema and a BMI of 30 who hadn't responded to diet or exercise, and low-dose tirzepatide reduced pain and inflammation in a way that other interventions haven't. So what's really important to keep in mind is that these are case reports and narrative reviews. They're not controlled trials. But the mechanistic rationale, it's solid. The early signals are consistent, and tirzepatide trials in lipedema specifically are being discussed in the research community. So again, we hope to have emerging research here. Where GLP-1 medications are, clearly useful would be in managing that secondary obesity in lipedema that we were discussing. So many women who do develop that generalized fat gain over time will respond to the medications much the way anyone does. So losing that layer reduces that mechanical load on the lymphatics, improves mobility, makes exercise more tolerable, and can make surgical outcomes better when surgery is the right next step. So to pull this all together then, lipedema is a condition with specific pathophysiology that makes it distinct from general overweight or obesity. The fat is different, the biology is different, and the standard fat loss approaches do not address the tissue directly. And when it comes to diet, low-carbohydrate approaches have the best current evidence for reducing pain and managing the inflammatory environment. It's not removing that lipedema tissue, but it's improving the quality of life for many women who have it, and that obviously is super important. And when it comes to exercise, do what you can pain-free and manage that as much as possible in the early stages of the disease. Low-impact movement that supports lymphatic flow will be protective, will be therapeutic, and can help maintain function. Surgery, such as that specialized liposuction with lymphatic sparing technique, is the most effective intervention for directly addressing the tissue. And the evidence for quality of life improvement is the strongest in the field, but it isn't first line and it's not for everyone. So that's important, again, to reiterate. And then those GLP-1 medications emerging as a useful tool, primarily in that secondary obesity camp. But, research will be emerging for its specific application in terms of the underlying pathophysiology of inflammation with lipedema. I mean, if you think you do have lipedema, the first step is finding a clinician who knows what they're looking at. As I said, it's still underdiagnosed, and the diagnostic criteria only became standardized internationally in 2024. So if you're someone who experiences it and you're like, I'm not getting traction on my diet and exercise plan as it's set out, that's definitely worth talking to your clinician about, particularly if you have some of these other indicators of lipedema. So guys, that's it from me. Hope you enjoyed it. You can obviously share this with anyone you feel would be interested in knowing a little bit more about lipedema or confirming what they already know. I'd love it if you shared this podcast with them. That's the way that Mikkipedia gets out there. Let me know what you think over on Threads, X, and Instagram at Mikki Williden, or head to my website, mikkiwilliden.com. Scroll right down to the bottom, pop your name on the email list, and jump on my email list for research updates, opinions, facts, recipes, the latest that's going on with me in my world. All right, guys, have the best week. See you later.